Here we go. Welcome everybody to another episode of The Big Idea. I am Dr. Jeffrey Hanna here with Clear Chiropractic, where we talk about the big idea. How it is that a very small vertebrae in your neck can actually have a very big impact in terms of your health, your well-being, and can change the quality of your life. We've got another really special video here today. This is one that hits particularly close to home, a little bit because this is an issue that I experience a little bit myself, but also one that impacts a lot of people and they don't realize the connection. We're talking about the connection between the jaw and between the upper part of your neck. As always, please do hit that like and subscribe and share this video with other people. And we'll start with the brief summary here first. And that is that there is an intimate relationship. The way that your jaw moves has a profound impact on the health of your neck. But the health of your neck also has a profound impact on how your jaw moves. And this can impact people in a lot of different ways. Headaches, migraines, vertigo, dizziness, tinnitus, but also a whole host of other symptoms that people do not as commonly associate with this area. Brain fog, persistent chronic fatigue, breathing issues, sleep apnea, and also different kinds of autonomic disturbance, and sometimes what's referred to as postural orthostatic tachycardia, sometimes what is referred to as orthostatic intolerance, digestive issues. The list goes on and on and on. And as much as I would like to say, yep, this is just that one little treatment that you need. All you need is an upper cervical adjustment. All that you need is prolotherapy. All that you need is physical therapy. All that you need is dentistry. No. There is a wide array of different things that are oftentimes necessary to resolve these kinds of issues. The good news is that by understanding what's going on, there are improvements that we can make. It's just a matter of being able to identify and understand these relationships so that you can find that breakthrough that you're looking for. If you've not seen any of our videos before, we always go through a brief story to explain to you what's going on, what our particular attention in the upper part of the neck is. We go through life, we have any number of physical injuries, slips, trips, falls, sports injuries, car accidents. What these do is these accumulate over a period of time. And there doesn't have to be broken bones or even bleeding for there still to be damage to the joints of your spine on the inside. In fact, even if you have a slip where you land directly on your tailbone, the force of that is likely to produce a shock wave that goes through your spine and is going to impact the weak link in the chain. And the weak link so happens to be where the base of your skull meets the C1 meets the C2 vertebra. Why? Because there's no disc that locks that joint into place. It's being suspended by muscles and ligaments. And what happens as a consequence of these injuries is it will very frequently see where there are shifts with a person's, why is my animation not working? Come on, little animation, you can do it. There we go. We will see resulting shifts in the normal resting position that impacts how these joints move. And these joints, these vertebrae, they have ligaments that are normally designed to anchor onto your spinal cord, which is going to be protecting that area when you move your head and your neck. The problem is if these vertebrae shift into an abnormal position, then what they do is they start to exert tension through that system, which is going to be not unlike poking you in the arm and being a persistent source of irritation over a period of time, because your brain is going to say, we don't really like this. What it's going to do is it's going to be making changes with your overall body alignment structure. We see changes in posture. It's one of the very first signs that can lead to tight muscles, that can lead to ligament injury. And as you see in the graphic here, it doesn't necessarily need to be right where the problem is. We say this all the time. Where the pain is not always where the problem is. And depending where you hold your stress, whether it's in your neck, whether it's in your shoulders, whether it's in your low back, that can lead to a variety of different things. Oh, but wait, there's more, because these problems in the neck can also affect circulation going up to your brain. It can also affect any number of brain-based functions. and push comes to shove, at the end of the day, there's nothing that goes on in your body unless your brain is ultimately commanding it to do so. The brain is the electric generator, the dynamo that is providing all of the information to all parts of your body. So we can appreciate then that if there's a problem in this area, it can impact you in any number of different ways. So from the upper cervical chiropractic perspective, what is it that we're looking to do? We're looking not to twist, not to crack. We recognize that every person is different on both the outside and also on the inside. We're then making a very precise correction without manual manipulation in a way that is going to allow for those vertebrae to be able to move the way that they are designed. If we're able to resolve that underlying injury, fortunately, we're going to see that that's going to be able to dissipate the tension. If we can dissipate the tension, your brain doesn't need to make these compensations down the rest of your spine. And guess what? It's going to do what your body is designed to do. That is heal itself. And as it heals, that's where we see so many of those different problems that are associated with this upper neck injury start to be able to resolve, and people can get back to doing the things in life that ultimately matter the very most. All right, so we're going to look back at a little bit of an older study that was done first that was looking at the relationship between what happens when you open your mouth and what happens in your neck. In brief, what they did was have a series of subjects, and they said, okay, we want to see how well you are able to normally open your mouth like this. Then what we're going to do is we're going to measure what's called the interdental distance. That is the distance between when you bite down like this, between your two front teeth on the top and then on the bottom, and they would measure that out. And I would encourage you to do this as a little experiment. What they found was that if you were to tuck your chin, do this as the experiment. Go ahead, tuck your chin down in, bring your head like this, and make like you're looking down at the floor. Something like that. And you'll notice my voice is changing even as we do that. Why? Because we're constricting the airway. But in that position, what you want to do is you want to open your mouth as wide as you can like that. Then what you do is tip your head back and open your mouth a little bit wider. Let me demonstrate that for you. So we're going to do this. We're going to tuck the chin in, open as wide as we can. Then I'm going to look up, and hopefully you can see even there that I can open my mouth wider just by tipping my head backward. That was the only change. And in fact, if we look at some of the numbers here for you without going through the whole of the study, actually I'll go through the summary part right here first. So the interdental distance increased from 28 millimeters with slight flexion on average, like this, up to 46 millimeters at full extension. In other words, they were able to get approximately 18 millimeters worth of extra jaw movement when you were able to engage the joints of your neck. And for people then, when they had deliberately said, okay, we want you to open your mouth as wide as you can, but we're going to, as is shown in this little picture right here, we are going to immobilize, make it impossible for you to actually engage the joints of your neck any other way. That when craniocervical, so that is neck extension, beyond the neutral position was prevented, the subject's mean interdental distance, ability to open the mouth, was 12 millimeters less than their mean at full extension, 26% less. And that is super duper important. It's showing, at least in this particular illustration right here, that the normal ability for you to be able to move the joints in your neck has a profound impact in terms of how well your jaw is actually able to open. Now, this is not just a one-directional kind of thing, because as we said, the jaw also affects your neck. Now let's have a look at a little bit of a more updated study on a few of these details. Alrighty, this one is a brand new editorial that's come out from the Journal of Craniomandibular and Sleep Practice. And what the gentleman here has done, he went and visited Dr. Ross Hauser. You probably have come across some of his videos. He's from Caring Medical down in Florida. He does a lot of cranial work. He does a lot of neck work. He does a lot of prolotherapy for people with instability. And he understands these relationships pretty darn good. And what the good doc here is describing a little bit about what they do. I thought that some of this was pretty novel. And so not only did I want to share this with you, but I also wanted to add a few things here where I think that they're missing a couple of very, very important details that go back to that study that I had just mentioned. So what does he describe? And don't worry, I'm not going to read the whole thing aloud for you. But fortunately, this is written in pretty plain English. He and his team, they take internal jugular vein measurements using ultrasound in various positions, including supine, that is lying down on the back, and upright, as well as various neck and mandibular positions. This information, along with digital motion x-ray of the patient's neck and an upright cone beam CT scan, is used to figure out which of 4 structural conditions are likely causing a patient's varied symptoms, which can include migraine headaches, head pressure, tinnitus, vertigo, dizziness, and a host of others. When a breakdown of the cervical curve or instability is found, cervical curve correction exercises, lifestyle modification, and prolotherapy of the cervical spine are prescribed. I do believe very strongly that they are missing the upper cervical component here, but nevertheless, 'tis what it is, and we'll add on that. If testing reveals an elongated styloid, the patient is provided with a surgical referral for a potential styloidectomy. If internal jugular vein compression is revealed because of a mandibular positioning issue, then an oral appliance and referral to a myofunctional orofacial dentist is recommended. All right. Okay, let me go ahead and break that down just a little bit first. What I've got here is a little model of the base of your skull and of the top vertebrae in your neck. Your jaw joint would basically be sitting approximately here. And there is this little space that we would have between where the jaw would be and this area right here. And we have a series of very, very important structures in this area. One of the major ones is the internal jugular vein. That is the vein that is normally designed to be draining fluid from your brain when you are in an lying down position. The vein has the tendency to shrink, to collapse when you are in the upright position. And that's one of the things that we believe oftentimes where people say, oh, I feel better when I lie down. And it's related to a host of other issues that I've talked about in other videos when you have irritation of what are called the cerebrospinal veins. Nevertheless, there's a major vein right here that drains blood from your brain. You also have the internal carotid arteries. They are the ones that are supplying 2/3 of all the blood up to your brain. And you also have a series of very, very important nerves. You have the glossopharyngeal nerve. That's the one that's involved with your ability to swallow. You have the vagus nerve, which is going to be sending all of the information to every single organ in your body, heart, lungs, digestive system, reproductive system, etc., etc. You also have all of the information that goes back up to your brain about the health and well-being of those various organs. We also have what's called the spinal accessory nerve. This is the one that is involved with your ability to move your shoulders, move your heads because of its action on your trapezius and your sternocleidomastoid muscles. But this is one that I think oftentimes gets forgotten. In fact, they don't even really mention it here in this particular study. It also includes what's known as the ascending sympathetic nerve chain. What this is this is a series of nerves that is ultimately going to supply and regulate every single blood vessel, lymph node for everything that is going on inside of your brain. And oftentimes people can be very, very quick to jump on vagus nerve dysfunction when a person is experiencing a sense of anxiety or they're experiencing lightheadedness or brain fog. And I would argue that this ascending sympathetic nerve is arguably even more important. Why? Because it's controlling every single blood vessel inside of your brain. Point being is that you have all of these essential structures that are in this little space between my fingers right about there. And what the authors in this particular study then are talking about, they're talking about how you can have mechanical compression of these different structures. And they cite 4 different reasons. 2 of them are actually connected. One of them is a loss of the cervical curve. The other one is cervical instability. One way or another, what that problem manifests as essentially is where this top vertebra will slide forward like this. And if that vertebra slides forward like that, guess what that's going to do? That's going to decrease the amount of space and become essentially a point of compression or irritation. Second thing that can, or excuse me, it's really the third thing that they're citing here that can cause this is what's called the elongation of the styloid. The styloid is, and I don't have it on this model here, it's an extension of bone that comes out right here. It's not this, but it would be located right through here. And if this is long because it's under chronic tension, that can become a proverbial pebble in your shoe. And when present, that can be, again, another reason why there is additional bits of compression. And if that's the case, really the only solution there is you got to get the pebble out. And that would be where a surgical consult is required. And the fourth thing that they cite is mandibular position. Remember I said that the jaw should normally be aligned right about here? Well, if for whatever reason, namely what's called a class 2 malocclusion, so that is an overbite, but it can also happen if there are developmental anomalies of the jaw. The jaw should normally be sitting nice and forward like this, but if for some reason the jaw gets pushed backward, there we are again. It's going to be producing compression of those various structures. And so what they're talking about here when they're doing the ultrasound, they're looking at the internal jugular vein as a proxy, a way of assessing to see if there's narrowness of the internal jugular vein, then there must also, by default, be some kind of disruption, irritation, narrowness, or constriction that are affecting these other structures as well, that internal carotid artery, that vagus nerve, that glossopharyngeal nerve, and also that superior ascending sympathetic chain. In other words, not just one thing necessarily going on, but you can look at the internal jugular vein diameter as a good way of figuring out, is there something going on in this area? So that's pretty neat, in my opinion. Okie dokie, so moving forward then down the article, what they illustrate for you here is a nice schematic where you can see these various structures that are involved. So here we would have where all of those vessels would be coming. Here is the location of the C1 vertebra, internal jugular vein, vagus nerve, internal carotid artery, and again, they're not showing the glossopharyngeal nerve, they're not showing the spinal accessory nerve, and they're also not showing that ascending sympathetic nerve that comes up through this exact same area. And they cite a few other studies, in a study of 108 consecutive patients, and that's a pretty big deal. Why? Because it would be very easy to use a sampling bias. We're going to select all the patients who so happen to show these kinds of things going on. When studies are done that use consecutive patients, it's a better representative sample about how common certain issues actually are. Now, granted, it's always going to be people who are presenting for care, but it means that when people have symptomatic, expressions like this, it means that, the data are more likely to be genuine. So in a study of 108 consecutive patients undergoing CT angiography, they were looking for arterial obstructions. They thought that there was going to be a problem with blood flow going up to the head. But what they actually found is that was not necessarily the case, but 50% of them demonstrated signs of internal jugular vein compression, and 93% of them were at the level of, guess what? That C1 vertebra, in other words, right there. Jugular venous outflow compromise is associated with many symptoms that can cause intracranial hypertension that can sometimes manifest as what's known as a normal pressure hydrocephalus, and whose classic symptoms include head pressure, lightheadedness, headache, migraine, nausea, vomiting, visual loss, sixth cranial nerve palsy. That's where the eye is basically starting to turn inward because we can't look outward, as well as swallowing difficulties, brain fog, photophobia, sensitivity to light, pulsatile tinnitus, as if you're hearing your heartbeat in your ear, and also vertigo. And I think that what they're doing here is pretty awesome. It's a novel approach where what they're doing is taking a series of internal jugular vein measurements with the person just simply biting their teeth together like this and then opening their jaw forward. They're looking then to see, to simply put, changing the jaw position, does that have some kind of a positive impact towards enhancing or improving that internal jugular vein diameter? Again, it may not be exclusively a jugular vein problem, but that is a proxy for measuring if there is mechanical tension of any and all of these various structures. And you can see on the CT scan they have right here, normal jaw position, and then this person deliberately sticking their chin forward then to see if there is going to be an increase in that diameter. So here would be a case of, and they've circled it, thank goodness, this black thing right, okay, so this big round one that you see right here, that is the internal carotid artery. And as you can see, it looks to be about the same. And this is because, at least we believe, arteries, they have very, very thick linings on the outside. And so it's going to be preserving the normal amount of space there as much as possible. But veins are relatively thin and floppy like that. In other words, it's more likely that you're going to see signs of compression and sensitive changes when you're looking at veins rather than when you're looking at arteries. So here was a case where they found somebody where, okay, in the quote-unquote normal bite position like that, that internal jugular vein was pretty darn well collapsed. And then by shifting the jaw forward, it opened up tremendously. And that would be then an almost pathognomonic sign from their perspective, and I would agree with this, that what this person needs is they need dental and myofunctional therapy. They need to change the structural position of the jaw if you ever want a hope in changing these person's kind of symptoms. Now here I thought was one of the really, really cool things here. The key measurement from the upright cone beam CT scans that Dr. Hauser and his team found is the mandibular axis distance, which is the smallest distance between the posterior mandible and the C2 vertebra. So even though they're finding that the vast majority of the points of compression are occurring at the level of C1, that if you're looking at where is the most accurate space, or in other words, where is the narrowest point, the narrowest relationship between the jaw and between the cervical spine, you actually want to look down to the level of the C2 vertebra, as they've illustrated in the diagram right here, where the back of the jaw would be located right here, and then this here would represent the front of the C2 vertebral body. So whether or not we're using digital articular images or we're using a CBCT, this measurement is a useful way to determine if there is sign of compression going on in a person's jaw with their neck that could be potentially relating to all of these different kinds of issues. Right. Now, the question oftentimes comes up, well, if I don't have access to all of these different kinds of testing methods, how do I know what's actually, going on? Is digital articular, our flexion extension views, are they necessary to look for signs of instability? Do you need to have the ultrasound, or are there other clinical signs that you can look for that suggest if there's this kind of disrelationship going on in the first place? And fortunately, the answer is yes. And they don't talk about them in this particular article, so I want to share these with you. We already know, first and foremost, about that very, very simple test. When you bite down like this, how wide can you open your mouth? And then, can you open your mouth wider if you actually engage your neck just as well? If the answer is yes, you can move your mouth farther open when you are able to basically lean your head back, well, that's a good sign. And that is oftentimes going to mean that the problem is not coming from your neck, provided that you're able to get like a whole, at least another 10 millimeters open. If you're only able to get 5 more, okay, odds are there is a bit of a problem. Now, if you are, on the other hand, not able to open your mouth really that much farther, then that would suggest that there is some kind of a neck issue that is restricting the jaw movement. Another very simple way that you can look at it is simply looking in the mirror straight ahead and open your mouth like this. Your jaw should move in a relatively straight line. The joints normally should flare in just a little bit like this and then extend out like that, and your mouth will open in a straight line. If it is, that's good. Now, if your jaw goes straight sideways one way, that is oftentimes signs of a structural issue with the cranial bones themselves. That, in my experience, that requires a dental resolution. If, on the other hand, your mouth does something like this, zigzag, then what we're having is a neuromuscular issue. Something is not quite coordinated right in terms of how your jaw muscles are working. And because there's a profound impact on the relationship of the C1 and the C2 vertebra in terms of how those nerves and muscles are able to work, that suggests that a person has an upper neck issue. And that's the case there for an upper cervical chiropractor. Now, is it possible to have both, where your jaw goes zigzag, where it does a little bit of both? And the short answer is absolutely yes. And this is one of the reasons why I talk about TMJ and I talk about dentistry so much. It's because I'm not a dentist. I know the things that I can help people with. I also need to know the things that I can't help people with. But sometimes the best help that I can be then is being that referral to get you to that person who is going to be able to help you out. And again, whether we are looking at a jaw position issue, whether we're looking at a neck mobility issue, or if there is that pebble in the shoe where, oh geez, you've got this extension of bone, that actually is going to have to come out. It's ultimately about finding what the best resolution is going to be. So those are just a few very quick and easy kinds of tests that you can do at home to get a sense of if you're having any of these issues, is your jaw, is your neck aligned, and who most likely started it? Now, here's where I start to disagree with some of the work that comes out of the cervical instability world with the prolotherapy. And it is the distinction that not all kinds of problems that are going to occur in the upper neck are as a consequence of instability. Simply put, where things are moving way too much. I would argue that a good chunk of the time it's because the right things are not actually moving well enough. And a consequence is if you have one part in your neck that is not moving well enough, the adjacent areas then start to move too much. In other words, the excessive mobility is a compensation for restriction somewhere else. And so guess what? You can have the stability shots, you can have the prolotherapy, which is, again, wonderful in a lot of circumstances. However, if you still have a restriction with joint movement, that is not actually going to solve the underlying issue. You have to find what that underlying restriction is. And this takes us all the way back to the big idea, how these little problems with neck mobility and restriction, where they are not moving the way that they are supposed to, comes into play. So what are these? What's this picture that I'm showing you right here? This is a picture of some data that I had collected in practice. This was of 300 consecutive people over a span of a couple of years. And I was doing what's called digital articular images. and I could update this now using CBCT. This is a different way, so not exactly the same as the digital motion x-ray, but ultimately looking to receive the exact same kinds of information. And what I was looking at was the relative amount of joint alignment. Any joint, I don't care whether it's in your neck or your low back or your little toe. It should, if your head is in a neutral position, it should line up like this. So when we see disturbances like that, that is a sign that there is a loss of the normal joint structure and function. And if we see a joint that is shifted this way, for example, then what that signifies is that it will not or is not actually coming all the way back down like this. Now this is going to come back around to what we were talking about with jaw position in just a second. Don't worry, I promise you that. But what you'll see on these particular data right here, we're looking at the C1, the C2, the C3, the C4, and also the C5 vertebrae. And I'm going to come back using my little models here like this. When you open your mouth, remember, your neck has to, or normally does a small amount of this movement right here, which means that it comes backward into what's known as extension. So when you open your mouth all the way, your jaw is supposed, or excuse me, your atlas vertebra is supposed to come back like this. Now the C2 vertebra, when you move your neck into extension, what it's supposed to do is it is supposed to rock back, also coming into extension as well. So what did I find? What did I find? I found that when people were coming into my practice, and again, these were people who were experiencing kinds of issues that required an investigation. We did some physical, we did some neurological tests to confirm, does this person, warrant having diagnostic images? And the short answer was yes. So for these people, when they were having problems, guess what we found? 78% of the time, they had forward misalignments of that C1 vertebra. 54% of the time, we found that there was also a forward misalignment of the C2. Now, what does that mean in terms of jaw function? Okay, let me start with the C1. If you've got the C1 vertebra where what it's done is it's misaligned forward, remember that space between the atlas and between the back of the jaw? If the vertebra misaligns forward, guess what? It has narrowed that space. And if we're finding evidence of an articular misalignment there, what that means is it means that that vertebra will not normally come backward. In other words, even if you do all of the stretches to lean your head back, that vertebra stays locked in that abnormal position. And what did we say? We said that in order for you to be able to move and for normal function of your jaw, that vertebra, as you open your mouth, has to be able to come back. If it doesn't, simply put, your jaw will not be able to move the way that it's supposed to. And this is something that I learned a very, very long time ago in clinical practice, that oftentimes the most difficult people for me to be working with, they have a structural TMJ issue. I have to refer them to a dentist. But conversely, the people who are most challenging for the dentists, they oftentimes have an upper neck issue. And that's where the upper cervical adjusting comes into play here, to be able to correct those misalignments, allow for those vertebrae to start moving, because if they're moving in the right way, guess what? Then your jaw is able to start moving the right way. So even if you are having myofunctional therapy, appliances, and whatnot, that gives it the opportunity to work at a much better, much higher level. And the same thing we found essentially at the C2. These forward misalignments, we're looking forward like this, cause the axis vertebra to shift forward like that just as well. And remember what they found. They found that the narrowest point between the back of the jaw and the cervical spine was actually using the front of this C2 body right here. So if that C2 has also shifted forward like that, guess what? When you bring your head back into extension, it will not come back as far as it is supposed to. And as a consequence, that narrowness can persist, and it means that that jaw is not going to be moving the way that it should be, and then can be in turn leading to so many of those different kinds of problems. And this is the reason why, again, I don't have an issue with prolotherapy. Where my concern is that prolotherapy in and of itself does not help to get these joints moving the right way. It helps to strengthen and solidify the ligaments. That's if they're moving too much. But what if the problem is actually that these specific vertebrae are not moving that right way in the first place? You can have the shot, but guess what? That underlying issue is still going to persist. And can you have instability of one area, but then so too little mobility in others? The short answer is absolutely yes. And this is one of the reasons why there is no one-size-fits-all answer when it comes to these kinds of conditions. It requires a collaborative effort with your myofunctional therapist, with your dentist, perhaps with somebody who does prolotherapy, perhaps an ENT or somebody who's able to do surgery if and where that styloid process is there. But also that upper cervical alignment is a huge factor in terms of making sure that your jaw, your airway, your skull, your neck, everything is moving the way that it is supposed to be. Because if it isn't, that then becomes a major source of tension in turn that shows up in a lot of different people's lives, disrupting headaches, migraines, vertigo. Again, the list goes on and on and on. And I know that that is absolutely a mouthful with a lot of different moving pieces. And that's one of the reasons why these kinds of issues can be so challenging for people, because there is not just one thing. And it's important then to get a broad understanding about what is actually going on. Where is your best bang for buck going to be able to get the resolution that you are looking for? So we know how to look for these things. We know what we're not able to do and where we need to make a referral, but then we also do know very much what our role is as part of a team in helping improve, enhance a person's quality of life. Now that is a little bit of a longer video than I've been doing in quite a little while here, because you can see there are a lot of moving pieces when it comes to jaw function, neck function, compression of the internal jugular veins, irritation of the superior sympathetic nerves, irritation of the vagus nerve, etc., etc. But I do hope that this video has broken that down, or at least given you a little bit of a broader understanding that there is not just one thing that can go on in this very delicate area, and that it requires a comprehensive assessment in order to get the best possible results there. So thanks for watching the video here. As always, we then ask 4 things for you. Number 1, if you haven't already done so, please do click that like and subscribe. Number 2, if this is something where you can think of a friend or family member who needs to know some of this information as well, please do share this video with them. Number 3 is if you want more information, or if you want to reach out to me personally, you can go to my website, which is drjeffreyhanna.com, where we have all kinds of other articles, videos just like this, talking about, again, what this problem in the upper part of the neck can actually produce, but also, and most importantly, how correcting it is able to help improve your quality of life. And last but certainly not least, if there's something that we can do to help you out, what we'd have you do is reach out to us at our clinic. We're at Spokane.com. Mention that you saw this video, and we'll be happy to coordinate a consultation with you and also do a series of tests to find out what we can do to help you out. You can alternatively give us a ring direct at 509-315-8166. We look forward to hearing from you, helping you, and doing the very best that we can. Thanks again for watching. This is Dr. Jeffrey Hanna at The Big Idea in Clear Chiropractic Spokane. Get well, live well, and stay well. Till next time, take care, and bye-bye.